Thank you so much for your extremely kind introduction, and thank you, Fujifilm, for having me here, especially in the presence of such giants, and thank you to ESGE. So these are my disclosures. It's already been 9 years, I think. Extreme excitement. They gave us LCI, and this was the bee's knees in terms of detection, and now we've got the evidence to back it. Over 1,500 papers supporting that it is better than white light to detect. But it was not enough. Of course, we need to characterize. So BLI came in, and several papers later, including by my dear friends who are the panelists here, with classifications. They've matched up to all other blue light, and this is the norm now. We characterize lesions with blue light. Again, lots of evidence to support it. But we have to set these aside for a moment, because today we are here to celebrate and introduce the birth of something that comes, I think, from a different galaxy. This is the latest processor, which has astounding optics and also a very new type of light. As if the optics were not clear enough, Fujifilm, being the giant that it is, looked elsewhere inside its huge portfolio to be able to see how it can define the image even further. And the analogy would be, imagine you wear Polaroid glasses to reduce the glare. And that's what they've done. When you have an image that you'd like to be brighter, there is a risk that in order to see the distance relatively clearly, the foreground becomes too white. You get the glare. And that's the elimination of halation. And this is what this series does. ACI, what a dream. So ACI is amber red color imaging, and it is a type of imaging that focuses, rather than on the magenta or the blue, like LCI and BLI respectively, on the red and orange spectrum. And you tell me, why is that? It was designed with blue in mind, not with amber red, because I'm an artist and I paint, and one of the basics for art is the color circle. What is directly opposite blue? Amber red. So put one drop of indigo carmine and you get phenomenal contrast. And this is what ACI is. It allows you to see the layers so much more clearly. And when you see the layers more clearly, that translates into many benefits. And you tell me, but I can get blue by putting in more indigo carmine. Of course you can. Do that. And then you won't see the vessel behind it, and you'll cut it. So this allows you not only to see the layers more clearly with blue, but it allows you to see the vessels within the blue. Absolute genius. Again, Professor Yahagi talked about it. I call the TP, as you know, Pradeep, a scope made by aliens or a transnasal scope on steroids, because it is a 7.9 millimeter.
On steroid and now a scope on steroid.
Company on steroid. Everybody's on steroids.
Yes.
I
A 7.9 millimeter scope. All right, 7.9, just slightly wider than a transnasal, with a channel that allows a London bus to pass through, a water jet, saline jet, CMOS, unbelievable, really. I'm not sure who you have working with you. I think you've got Star Trek. And of course, they've designed the hoods in relation to this. But let's stop talking. Let's show you some cases. So we'll start off with a video that was edited by my dear fellow in the front, Georgios here, who drew the graphics. So we used the latest generation, of course, 8000 series. And we're going to flick through LCI and BLI, which you know well, so I'm going to scrub through this. But I like using LCI also to highlight the vessels as I inject. because I find it to be the best modality to avoid that puncturing the vessel. Because as you know, when you start an ESD and you puncture a vessel, it's a big headache. So we avoid the vessels with LCI. And then I'm going to start making an incision. So we're using a Fujifilm colonoscope here. This is ACI already, but it's not coming into its own yet. We're not diving into the submucosa yet, and you'll see once we get into the submucosa how beautiful this is. So we're in the ascending colon for a lesion with a Fujifilm colonoscope. We're using the flush knife 1.5 millimeter, the usual story of trimming, and now we'll start seeing the beautiful story when we get into the pocket. So a bit more of this section here, and now we're in the pocket. And you can see that blue, that beautiful blue. And behind it you can see those vessels. So this is white light, and now we flick back shortly into ACI. And you see the color change. Unbelievable, really. So that makes you see the muscle layer much more clearly. And if you can see your friend, the muscle layer, you're not going to hurt your friend. So, you know, there's no friendly fire. Look at these beautiful graphics that show the distinction. The muscularis propria is extremely clearly seen all the time. And even the base of the lesion, the underside of the lesion, because you don't want to damage that either. So this is designed for what we do now in complex endoscopy in the third space. And again, highlighting this beautiful layer separation or layer recognition. Let me go to this bit now, because I have to plug in my saline immersion technique, which Professor Yahagi also uses the saline pressure. So we are using saline to coagulate here. So we coagulate using the saline pump plus the coagulation pedal, and we call that the frozen effect. And you're going to see it here. Everything goes frozen. It's as if you've got a tree that went white. And this is really, really good for pre-coagulation, because as you know in ESD, the more you have bleeding, the less you speed up, okay? You slow down. And we try to use the knife alone to actually pre-coagulate vessels or coagulate vessels as they bleed. And if there's a very big bleed, nowadays I don't even use a coagulation forceps, I use the Purostat inside, but that's another topic to discuss. But this is a whole armamentarium. So now we have completed the exit into the bridge. We're going to make the full bridge. This is the bridge formation variant of the pocket creation method as designed by Professor Yamamoto, my mentor. And then we finish off this section by completing it like so. We made some pillar in the middle, and then I'm going to scrub through to give you another case. All right, and I'll show you the final specimen. So not a very small lesion. Case 2 is a bizarre case. So this was total of about 16 centimeters in the sigmoid colon. And I think this brings out the beauty of ACI when combined with, as Professor Hagi showed you, the TP scope, because we use the TP, and the saline immersion technique and the ability to retroflex very well. And I still mention the saline immersion because I'm going to show you a feature here that lends really well to the TP. Look at the down and up angulation. So that was the up, and this is the down 160. You've got this white tube, and I'm going to pause it here. I'll go back a bit. This white tube is a nasojejunal tube which we wrap around the scope and tape it. And because it looks like a serpent, the staff of Asclepius, the god of Asclepius, we called it the Asclepius tube. It was developed with Gici in collaboration with Gici. And this allows for drainage of excessive saline and allows us to do most of our procedures under conscious sedation, because if you have a comfortable patient, you can go on. And you tell me, I don't like using saline or water. It works for gas as well. The less distended the patient, the more comfortable. But let's speed up so that I'll show you the case, because it truly is unbelievable. So this was the proximal lesion. this video was edited by Dr. Maristani Bosch, who's from Barcelona, is also in the audience and is my second fellow. And thankfully, I had a bridge between the two lesions, because it would have been a nightmare to try to resect this completely in one piece. So we resected the distal lesion first. There was confirmed high-grade dysplasia inside it, and the TP truly allowed us to dissect this with the least possible stress. Again, ACI coming into full view, beautiful visualization of the muscle layer and of the lesion, and also those vessels shining through the blue, which you do not get if you've got a very concentrated solution of indigo carmine. And this is the frozen effect again, with the saline coming into play with the knife. We'll look at this vessel. I think this one will bleed, if I remember correctly, just to show you possibly what we do. Yes, this bled a bit, but we will probably coagulate it with the knife and carry on. Now, in the real-life scenario, if this continues to bleed, I usually put a bit of Puristat, but that we stopped. And we kept going up and up and up, and the TP was really, really helpful in the tight angulation of the sigmoid colon with all its conundrums that it throws at you, as Professor Yahagi was telling you to. So we'll scrub, 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 going to the last lesion. So we passed the bridge, and we went to the second lesion, and then in a similar fashion to what we had done for the distal lesion, we eventually, finally, released the last lesion. And look at the dissection site here. Okay, this was practically the whole of the sigmoid colon, and when the lesions were resected, they showed to be themselves to be absolutely huge. R0 resection with high-grade dysplasia, all thanks to ACI and the TP. Another case that I will show you is the combination of I will skip this case. I'm going to show you something else. I will show you a case that was extremely difficult because it was inside the transverse colon in someone who had an impossible sigmoid, stuck down with adhesions, a hernia, and it was impossible to get to the transverse colon very safely or to get the stability that you need. So another gift from Fujifilm, double balloon. So this was a DBE ESD. And it will come into play to show you what we can achieve with DBE ESD. So this is using the Fujifilm flash knife, again with ACI in retroflexion in the transverse colon, and with absolute stability. And you can see the difference here again, just in case you're not convinced that this allows you to see things properly. And it wasn't a very tiny lesion. Here we have a big episode of bleeding, but we stopped it with the Puristat and intraknife coagulation. So we apply Puristat here. I tend to put a dollop. I ask my fellow to put some pressure on the lesion, on the flap. I go for a coffee, come back, lesion has stopped bleeding, carry on the dissection, and that saves us the use of a lot of excessive heat, because that is what translates into a delayed perforation if you use a lot of heat. So lesion out, and that's...
So you see how speed they can go underwater, eh?
Don't say what. All right. So first impressions, guys. ACI allows very clear layer recognition. It works best with dilute blue dye because that's what it is designed for. The color circle, contrast, blue is opposite amber red, and that is why it comes into its own. Vessels are very clearly visible through the blue because in ESD, visual clarity is key, and it translates into less damage of the muscle, less episodes of bleeding, safety, and efficiency. All right, and hopefully we'll have studies now to actually confirm this in absolute trueness. I thank my team, who's all in the audience, and come to the AM in Malta. Thank you.
So, open for questions. Any questions from the audience? Ed, while people come up with questions, we heard about the suction, the channel size, the down angulation. One of the other things when you do ESD, I know that you are a very, very good endoscopist. You probably do ESD very quick, but they're long procedures, 3 hours, 2 hours, and that can be very taxing. So anything about ergonomics of this endoscope, the visual clarity, because I suffer with dry eyes, and when I'm looking at screen for long, my eyes begin to hurt. So can you comment on that side?
Thank you, Pradeep. Thank you. So yes, I mean, it's a very light scope because its diameter being so narrow gives it this light thing. So it's light. It's very easy to handle, and the movements of the wrist are enough to actually move the tip of the scope. And I think that the clarity that it produces causes less strain on the eyes. Now, this is not something that is absolutely proven. It's anecdote, but I think, yes, if you can see clearly, you're going to get less stressed, you're likely to take less long to complete the procedure even safely.
There is a question.
Thank you very much for this very interesting presentation. My question regarding the Burostat. You use the saline, and how can you apply Burostat to the vessel?
You do, because when you have this episode of bleeding, you put in a bit of carbon dioxide, you put the Purostat, you put the pressure on the flap, you give it about 5 minutes. That's why I go for a coffee. It's not a joke, to allow it to set. Because if I stay in the room, I'm going to be tempted to disrupt it, and then I will have a big problem on my hands a bit later.
When
But
you're
it
in
does
trouble,
work even in the presence of saline.
when you're in trouble, you can also inject it with a standard needle.
Yeah.
You can convert it in a standard syringe, the Purostat vial, and you can inject as a saline. It's very effective as well.
It works really well.
Yeah.
Thank you.
Okay. If no other question, thanks, Ed. Thanks so much.
Thank you so much.